this patient, we had an informed discussion with the patient, went through all the risk, benefits, and alternatives. We did have a neoadjuvant study available, but the patient opted to undergo surgical resection, and we did that. Now, at this point in time then, would we consider adjuvant therapy for this patient now when we know she has recurred and we know that the risk of having subsequent recurrences are exceedingly high? And if so, outside of a clinical trial but currently available adjuvant therapies, what are the therapies that we could choose for her, Tony, if she came to UCLA?
So this patient would be referred to medical oncology for adjuvant systemic therapy, and we would be discussing at this point high-dose ipilimumab, meaning ipilimumab given at 10 milligram per kilogram, which in the recent ERTC trial has demonstrated improvement in overall survival significantly to the control arm, which was a no treatment control arm. Would also discuss high-dose interferon. The likelihood of a serious side effect from high-dose interferon would be lower than with ipilimumab, but the common toxicities will be higher with high-dose interferon. Those would be the two options.
What are the common toxicities, Tony, in the high-dose interferon that would be different from the high-dose ipilimumab?
So high-dose interferon will give toxicities in the majority of patients. It's given intravenously for 5 days on, 2 days off for a month, and during that period of time, the majority of patients have fevers and chills and malaise. Many times treatment needs to be stopped because of pancytopenia or elevation of liver function tests. And then the patients would continue with getting dosing subcutaneously 3 times a week for a year, where the patients with continued dosing have a sensation of being really tired most of the time. And with time, they can develop depression, something that's not only because they're on treatment and they have had melanoma surgery, but because interferon alpha-2b can induce depression, and it's been something that's well recognized. High-dose ipilimumab, in the majority of patients, will have no adverse side effects. We forget about this when we talk about the high-dose ipilimumab because all of us are worried about the ones who have side effects. And the ones who have side effects can have colitis that can be severe, that can be difficult to manage. We're talking with the first case about treating with high doses of corticosteroids and not being able to taper rapidly, which becomes a bigger problem in patients where some of them may be cured from the surgery, yes. And now we've induced toxicity and we have to deal with that toxicity. Some patients may develop hypophysitis and may then require substitution therapy, mineralocorticoid therapy for life, and having to watch their lifestyle because at some point, if there's a need if there's a stress situation, their body would not react to that, and that may be a problem. Thyroiditis and other itis that can be seen with ipilimumab. So those are things that come into big consideration in this case. Those are the other therapy that would be approved in the US is pegylated interferon, which the side effects are similar to high-dose interferon. The data does support using it. There's no overall survival advantage in the randomized trials, and patients with an ulcerated primary, there's a hint that maybe pegylated interferon may have more activity, but that doesn't mean that high-dose interferon will not.
Again, albeit on sort of ad hoc analyses, not sort of predefined analyses in this. Now, Antoni, so with this then, so the EORTC 18071 study, which is looked at high-dose ipilimumab, 10 milligrams per kilogram versus the placebo, that showed both an improvement in recurrence-free survival and also recently in overall survival. I think it's also important for us to recognize, though, that in this adjuvant study, there were 5 patients on the high-dose ipilimumab arm that actually died. I think it's also important to recognize that many of these patients, as you indicated, they may have been cured with surgery alone. So I think that's a very important discussion for us to have.
Absolutely.
Now, Tony, the other thing that we're seeing also in the community, as we know that the approved dose, the dose that we use for patients with metastatic disease, ongoing metastatic disease with ipilimumab is 3 milligrams per kilogram. And yet now the approved dose then in an adjuvant setting is 10 milligrams per kilogram. And there definitely is more toxicity with that. In the community, we are seeing patients being treated with 3 milligrams per kilogram with really no data at all to support that. What is your take on this? I know there are some clinical trials that we have conducted that will look at this, but at the moment, what is your take on this?
So it's a difficult question. And I've found myself tongue-tied more than once whenever I'm talking to patients about the ipilimumab dose in a more serious condition in metastatic disease. It's a third lower than in the adjuvant setting, where some patients may be cured and we would be more careful about side effects. The data so far suggests that there's a dose response effect with ipilimumab. There was a presentation at this year ESMO meeting of 3 milligram ipilimumab at 3 milligram per kilogram versus 10 milligram per kilogram in patients with metastatic disease, suggesting that there's showing that there's improved outcomes on patients with 10 milligrams versus 3 milligrams. So if we think about the therapeutic effect, it may be more beneficial to be in the high dose on the 10 milligram per kilogram. The problem is that also brings a lot more toxicities, and then we have to consider that. But the data of adjuvant ipilimumab is with the 10 milligram per kilogram, so we cannot change that. That's a trial that took several years of planning, conduct, and readout. And we cannot change it right now. And my standard is giving the 10 milligram per kilogram dose and hoping that the patient will tolerate it. The 3 milligram per kilogram is being tested prospectively in the ECOG trial, A1609, which has 3 arms: high-dose interferon, ipilimumab at 10 milligram per kilogram, or ipilimumab at 3 milligram per kilogram. And that study, we hope that will read out in the next 1 year or so, and then we'll be able to see what is there another benefit in the adjuvant setting to be on the 10 versus the 3, and then what are the differences in toxicities.